Hello, everybody. Today we will talk as part of the training for gene and cell therapy about clinical applications of gene and cell therapy, more precisely about CAR T-cell therapy. So treatment of cancer has for a long time been dominated by surgical intervention. During the last century, there were successes with radiotherapy and also with chemotherapy, but the research done in the last 50 and 60 years has especially focused on molecular targeted therapies and also on immunotherapy. The idea of immunotherapy is not new at all in medicine because there were some successes during the last century, but during the last decade, the success was very impressive and it became a focus in medical research and also in new treatment options that has been developed since then. The idea of using the immune system for treatment of cancer is not new at all. It has been dominated by two guys, Lewis Thomas and Burnett, more than 60 years ago. Why do we think about using immunotherapy for cancer? There are some items in cancer that are an indicator for that. For example, patients receiving immunosuppression, for example, for rheumatological diseases or for the organ transplantation, have a higher risk for developing cancer. A second argument is that tumors that demonstrate a high infiltration rate by lymphocytes and other immune cells have a better prognosis. So we have a certain type of immune reaction against the cancer. It's not effective enough, but when we see that, it is better for the patient. And finally, we can see sometimes spontaneous regression of cancer. And when we see this spontaneous regression, most often we can find a lymphocyte and immune infiltrate in the region where the tumor was before the remission. What are the strategies for immune therapy in malignant disease? We have two options. Sometimes we know the precise antigen, and then we can consider treatments like vaccination. We can consider monoclonal antibodies. We can use an adoptive T-cell transfer. This is CAR T-cells. Or we can use BiTE antibodies. BiTE means that we have bispecific antibodies that engage T cells to react against the cancer. But we have also sometimes situations where we don't know the target of the immune reaction. And that's, for example, what we are doing since 50 years with allogeneic transplantation. Allogeneic transplantation is a treatment option that can heal lots of leukemia and other malignant diseases, and where we have also an immunological reaction against the tumor. The same is the case when we use donor lymphocytes against leukemia. But since about 10 to 15 years, we have also other unspecific immunotherapies without knowing the antigen. This is when we use checkpoint inhibitors. In a lot of solid tumors, we use that. We have also, in the meantime, checkpoint agonists, and we have cytokines, what we use in cancer treatment. So sometimes we know the antigen, we are very specific. Sometimes we don't know the antigen, but that can also be considered as a very effective treatment option for some clinical situations. But today, we will focus on CAR T cells. What are CAR T cells? What is the indication? What are the results? How to applicate CAR T cells and what are the side effects? And what is the future for CAR T cells? When we consider the reaction between a T lymphocyte and an antigen-presenting cell, we have on the side of the lymphocyte, we have a T cell receptor, and this T cell receptor will recognize a peptide presented by the MHC complex, and the MHC complex is on the surface of an antigen-presenting cell. and a tumor cell can also be an antigen-presenting cell. But this signal is not enough to have a real reaction of the immune system. We need a second signal. This is a co-stimulation. And the co-stimulation is, for example, CD28 on the surface of the T lymphocyte, who will recognize, for example, CD80 or CD86 on the other side of the antigen-presenting cell. So we need two signals. This is important. This is what have given a real boost to the development of CAR T cells. We need a key to open the door, but in addition to the key, we have also to push the door to finally enter the room. So two signals are necessary for efficacy of CAR T cells, and maybe in the future we will have more than two signals, 3 or 4 signals will be considered. Why the immune system will not fight against every cancer cell? Because cancer cells have most often antigens on the surface. So there may be some recognition, but it's not sufficient to fight against the cancer and to kill the cancer cell. Why is it so? The cancer cell is able to hide the surface antigens, and so the immune system will no longer be able to recognize the cancer cells and to fight against these cells and to kill them. So this is why a tumor can develop. But you have other proteins on the surface of the cancer cell that are more or less specific for this cancer cell, but you have to look for such proteins and you have to develop treatments against the surface antigens on a tumor cell. This is what has been done in the last 10 or 20 years to develop CAR T cells. So you have a protein on the surface of the cell, and this protein can be recognized by a receptor. So what you do is you take the lymphocytes from the patients, you do a genetic transfer, you have this new receptor on the lymphocyte, and this new receptor will finally recognize this protein on the surface of the cell and can so fight against the cell and kill the cell. This is the mechanism of a CAR T cell. This has been first developed for lymphoma, and when you look here, for example, for a lymphoma cell, you have on the surface of a lymphoma cell of B cell type a certain protein called CD19. This is considered as a tumor antigen. It's not specific for a malignant cell, but it's specific enough to be considered as a specific marker of the B cell lymphoma. And you have the antigen on the surface of the lymphoma cell, and you have a CAR T cell who is a lymphocyte coming from the donor, who has still his endogenous T cell receptor, but in addition, he has a second receptor, the chimeric antigen receptor, that will finally recognize the tumor cell as foreign and to attack this cell. When you look more in detail, this receptor that you have transfected to the cell, you have especially 3 parts in this receptor. You have first the specific binding site of the receptor. This binding site is most often part of the variable domain of an antibody. This part will specifically recognize the antigen on the surface of the tumor cell. In addition, you have a co-stimulatory domain. So as I told you, need 2 signals. This is most often CD28 or 4-1BB, 2 co-stimulatory domains. And in addition, the third part is the zeta chain of the CD3, so the normal receptor of the T cell. And when you have a contact between this variable domain and the tumor antigen, the signal is enhanced by the co-stimulatory domain, and the T cell is finally activated by the zeta chain of the CD3 molecule. So this is how it works. In daily practice, how treat we these patients? First of all, we do an apheresis in these patients. So we take blood, we do centrifugation, we give back red blood cells and plasma, and we only maintain the lymphocyte part of the product. And this product is purified for T cells. This is not done in the hospital. Most often it is done in a pharmaceutical company. Also the second part, the transduction of the cells by the construct what I have shown you. After transfection, you have an expansion of the T cells. You have a culture of 7 to 10 days most often, but this production period, this culture period is more and more shortened in most companies and most new products. Then you have to check if the product is not contaminated by bacteria or something else. Then you give the product back to the physicians. We give the patient some mild chemotherapy. This is to stimulate the immune system, that there will happen something, that there is a stimulation for development of new lymphocytes, and you will give the cells, the transfected cells, back to the patient. So this is the process. It takes more or less 3 weeks between the apheresis, transfection, culture, coming back the cells to the origin, and giving the patients chemotherapy and giving back the cells. So the process takes around 3 weeks. Part of them is done in our hospital, so the indication which patient will receive the treatment, we have to prepare the patients, we have to prepare the procedures, we need a good timing. The transfusion medicine department is doing apheresis in our hospital, and they send the product to the pharmaceutical company. When we know cells have been produced successfully, success rate is different from one product to another, but it's between 90 and 95%. So for most patients where we consider do CAR T-cell therapy, we will finally obtain a product and can give it to the patient. And then we will start with the chemotherapy and give the cells back to the patient. There is a lot of teaching necessary for the whole staff involved in the treatment of this patient, a lot of documentation. You need documentation of all side effects, complications, and also follow up. CAR T-cell therapy has become famous about 12 years ago due to a young woman in the United States treated at the University of Pennsylvania, at the UPenn. She was 13 years at this moment. She was suffering acute lymphoblastic leukemia. She received chemotherapy, stem cell therapy, antibody treatment without any success. So finally, she was lost, and the team decided to give her CAR T cells. Until there, CAR T cells had been tested also in lymphoma, especially in chronic lymphocytic leukemia, and success rates were not so high. But this young woman has been healed by the CAR T cells she received 2013. She's still in complete remission 12 years later. And this has been a real big success in our field of hematology, and all hematologists were delighted by the start of a new era of treatment. The young lady is Emily Whitehead, and she's collecting funding for development of CAR T cells in the United States. So if we have a new treatment option, we have also to think, is there a need for a new treatment? So why do we need new treatments? Sometimes because older treatments are not effective enough, we have not enough remission, or also sometimes because our treatments are not possible due to age or due to stem cell collection problems, or because the treatment has too much side effects. So there are lots of reasons why we need a new treatment option. And the best example to explain that is the diffuse large B-cell lymphoma, DLBCL. It's one of the most frequent B-cell lymphoma in adult patients. And if you have 300 patients suffering this disease, 2/3 of them are healed by a normal chemotherapy, what we use every day, but 100 of these 300 will have a relapse or will be refractory. And only half of these patients will be eligible for an autologous transplantation, but lots of them will not respond to a treatment what we have to do before the autologous transplantation. And finally, only 10 of these 100 will be cured by the chemotherapy and autologous transplantation. And half of them are even not transplant eligible, and they cannot be cured at all. So this is a disease, when we have a relapse, there was a really, really big need for improvement. And this is the first study that has been published. So it's a ZUMA-1 study. So 1 is really the first study in this indication of DLBCL. And the new treatment with CAR T cells has been compared to standard of care. So SOC means standard of care that has been collected from a lot of sites doing this treatment. So, and you can see that survival with standard of care treatment was only here 20% after 2 years. So very poor prognosis for these patients. And with the new treatment with CAR T cells, you can see here 54% of survival after 2 years. So this was not a randomized study. This was a historical comparison, but you have a 73% reduction of death rate for these patients suffering this disease. So after these results, treatment with CAR T cells has been approved by the FDA and also by the EMA. And this is what we have done for 2 or 3 years. But this was a treatment after 2 or 4 lines of treatment. And the second or third relapse after chemotherapy and autologous transplantation. Then this new treatment option has been compared to the standard of care in second line. This is why you can see here ZUMA-7. So it was a further trial that has been initiated by the pharmaceutical company. And when we talk here about the black line, this is the standard of care. This was composed of chemotherapy, collection of stem cells, high-dose chemotherapy, reinfusion of stem cells. And we can see that we have only 60% of event-free survival after 2 years. So very poor prognosis. Compared to the CAR T cells, this was really a group of patients with a very poor prognosis. You can see that we have 40% of event-free survival after 2 years. So here also a huge difference in event-free survival and improvement for this patient group. Why is this treatment better? Several reasons. You can see here on the left side, this is a response rate of the CAR T cells, and you have a response rate of 83%. 2/3 of them are complete remissions, and some patients have only partial remission, but we also benefit from the new treatment. Not a lot of patients have a progressive disease with CAR T cells. Compared to the chemotherapy plus autologous transplantation, you have only a response rate of 50%, and much more patients have progressive disease even during chemotherapy and autologous transplantation. So this is one of the first reasons. Why is it better? But it's not the only reason. To start here, only look on the left part of this slide. This is the same trial, and you can see here on the left part the standard of care, chemotherapy, then collection of stem cells, then high-dose chemotherapy, giving patients back the stem cells. Only 36% of these patients finally received the whole treatment because there was no response to chemotherapy, because not all patients were collected successfully for stem cells. So lots of reasons why this treatment option did fail finally. And that compared to the CAR T cell therapy, 94% of these patients in this treatment arm received finally the CAR T cell product. So production was successful, and there was not a lot of other chemotherapy necessary to obtain these results. This was one of 3 trials that was done by a CAR T cell product called Axicell, but there are 2 other products also on the market. These are Lysocell and Tisocell, and you can see the same phenomenon. CAR T cell therapy was possible for most patients, compared to the standard of care, with chemotherapy and autologous transplantation who often failed. So failure of treatment is also a reason why CAR T-cell therapy is better than chemotherapy in addition to autologous transplantation. Some other features are important in CAR T-cell therapies because high-dose chemotherapy with autologous transplantation, also allogeneic transplantation, are possible up to 65 years, but in patients older than 65 years, it's not always impossible, but it's more difficult. You have a higher side effect rate, higher mortality in these patients. And so there was a special focus also on patients older than 65 years. And you can see here the same phenomenon compared to the standard of care with chemotherapy and autologous transplantation. Patients receiving CAR T-cell therapy have a much better outcome. Here, 47.8% compared to 15% in the chemotherapy arm. So this is also improvement because these patients wouldn't receive at all treatment with a curative option. Now they have also the possibility to obtain a treatment with the potential to cure the patients. And the oldest patients what we treated with CAR T cells in our center was 80 years old. She did it very well. She was just hospitalized for 3.5 weeks, and she's in complete remission since more than 1 year. And this is also a particular point in this treatment. You can see here, when you have relapse, the relapse after the CAR T-cell therapy will be seen here in the first 6 months in most patients. If you have a remission after 6 months, you have a kind of plateau. It's not a real plateau. You have sometimes patients that relapse, but most patients that didn't relapse after 6 months can be considered to have a long-term remission. If it's cure, we don't know it. CAR T-cell therapy is not established is only established since 5 to 10 years. So we have no long-term results after 10, 15 or 20 years, but we have a kind of plateau. And we hope that the remission will be as long as possible, or maybe some of these patients will be healed finally. You can measure CAR T cells in the blood of the patients after receiving these CAR T cells. And you can see here that patients that respond to the treatment have higher levels of CAR T cells than patients that didn't respond to the treatment. So you have more expansion of the cells when you have response to treatment. And there is another interesting item, in my opinion, about CAR T cells. What you can see here on the left is if you have a higher amount of lymphoma cells at the start of your treatment. So here 2 exponent 14 means a very large volume of lymphoma. You have a very low response rate. If you have less lymphoma, you have a higher response rate with conventional chemotherapy and autologous transplantation. When you look the same here for CAR T-cell therapy, you have also a decline in response rate when you have a higher volume of lymphoma, but it's not at all as impressive as with standard therapy here. So the response to the CAR T-cell therapy is a little bit dependent on the tumor volume, but you have also patients with a high volume of lymphoma that can be treated and they can obtain remission of the disease with a CAR T-cell therapy. Also important, in my opinion, is what I have shown you until now are results from clinical trials. But we also know that sometimes when you have a treatment really in real world, that results are not as good as in clinical trials. This is a known phenomenon in medicine, but we had a surprise in CAR T cells because you can see here the results of real life data. These are data from Europe, but you can also show real life data from the United States in the literature, and results for progression-free survival and also overall survival are as good in real life as in the studies. Response rates, progression-free survival, also all the results are really comparable to clinical trials. So this was quite surprising, and fortunately we could extend the number of patients, the patients that can benefit from the treatment. results are even better in real world. And I will show you why. Because we have learned how to treat the side effects of the treatment. You can see here the ZUMA-1 trial, so one of the first trials, what has been done with CAR T cells, with axi-cell. And you can see here in orange, severe side effects, grade 3 or 4, in this ZUMA trial. This is a neurological side effect. We will talk about that in a few minutes. And this is cytokine release syndrome. And you can see here higher rates of severe side effects in this first trial than in real life data a few years later. So we have learned how to manage this treatment. And this is quite good because patients have less side effects and finally results are even better. Other factors have been studied to know which factors are finally important to know if a patient will profit from the treatment with CAR T cells. And these are now real-life data from the CIB-MTR, so the US registry. And you can see here that the general health status, the ACOG of the patients, 2 or above 2, is the most important factor for overall response rate, duration of response, overall survival, and progression-free survival. As well as hepatic disease is also considered as a poor prognosis factor, but other frequent comorbidities in older patients, like renal disease, so kidney failure, cardiac disease, pulmonary disease, prior cancer, or obesity, have not a real impact on overall response rate, duration of response, and progression-free survival. Renal and cardiac disease have an effect on overall survival, but this is also due to the failure of these organs and not only due to the lymphoma that has been treated. So this is also quite impressive. Age has not a big rule in treatment decision. Lymphoma volume has not a big effect on response, and so the same is true for prior cancer, obesity, and a lot of other factors. Finally, the general health status is the most important factor when we decide about treatment for this patient or not. This is the same, just a little bit later. So I talked a lot about diffuse large B-cell lymphoma. What about other diseases? There are quite impressive results also for Brexu cell in mantle cell lymphoma. You can see here that the response rate of Brexu cell in mantle cell lymphoma is 93%. Duration of response is also quite good. And you can also see here that if the patient has no relapse after 12 months, there is a kind of plateau. Progression-free survival shows the same effect, and also overall survival, the kind of plateau after 2 or 3 years seems possible. And not surprisingly, patients with a complete remission or with a partial remission have better duration of response than patients without complete or partial remission. Next disease is multiple myeloma. Multiple myeloma is known to present a specific B-cell receptor on his surface. It's a B-cell maturation antigen, BCMR, and lots of drugs have been developed against this protein on the surface of the myeloma cells. Antibody drug conjugates, bispecific antibodies, but also CAR T-cell therapies have been developed against BCMA. And one of them, and the most popular in the meantime, and the only one on the market in Germany in the meantime, is ciltacabtagene autoleucel. And you have also here a binding domain coming from the light chain of a variable domain of an antibody with a co-stimulatory domain for 1BB and the zeta part of the CD3 molecule. And you can see here that the overall response rate is quite high, 97.9%. And you can also see here that progression-free survival is quite good. We have still at 24 months, all patients a progression-free survival of around 60%. So this is also a CAR T-cell product that is approved in Europe for the treatment of refractory myeloma after 2 further treatment lines. But when we talk about new treatment options, we have also to talk about new side effects. And there are 2 side effects that are specific for CAR T-cell therapy. And the first of them is the cytokine release syndrome. So you have T-cells of the patients, you modify these T-cells, you give them back to the patient, and these T-cells will find an antigen, they will grow, there will be a big proliferation rate of these cells, and not surprisingly, they will release a lot of cytokines. There are some of these cytokines that are more important than others. The dominant cytokines, what you can see in CAR T-cell therapy that will grow, are interferon gamma, TNF alpha, and interleukin 6. But there are also other cytokines that will grow up when you have when you give CAR T-cell therapies, and this can finally result in a cytokine release syndrome. What is it clinically? When you have a patient with a cytokine release syndrome, it's like a big infection, like a sepsis. So they will have tachycardia, they will have tachypnea, they will have chills, fever, they will have dyspnea. And these patients are really sick, and we have to look for these patients every day, 2 or 3 times, in the morning, in the afternoon, in the evening, and in the night. If they develop such a clinical situation, we have to treat them for that. We will not just wait, but we will look for these patients really in detail. This side effect CRS will start 2 or 3 days, typically after given the CAR T cells, but it can go up to 9 or 10 days. Okay, so there is a peak after around 1 week where we can see this cytokine release syndrome. There is a second part of side effect specific that you can see here. This is neurological. It's a kind of neurological CRS. It's called ICANS. And it will appear also during the early phase after the CAR T-cell therapy, but a little bit later. It will start around day 5, but it can go for up to 2 weeks. And we have to check the patients every day for these side effects. You can see here, we have to look for the temperature, we have to look for blood pressure, we have to look if there is a good saturation of oxygen in the blood, and we have to check that every day in these patients for 14 days at least after giving the CAR T cells. And when the patients develop CRS, and this is frequent, more than 60 to 70% of the patients will develop CRS, there is a recommendation, a very precise recommendation for treatment, and the treatment is related to the severity of the CRS. So there may be a CRS grade 1, it's only a little bit of fever and a little bit of dyspnea, but not severe. We have simply to monitor the patients. If it will be more severe, the patient will receive oxygen, will receive fluid, will receive antibiotics, etc. So there is a grading, and according to the grading of the CRS, we will give the correct treatment to the patients. If the patient will develop CRS grade 3 or 4, then the patient has to go to the intensive care unit because there is need for more monitoring. So this, for example, the precise treatment of CRS grade 2, we don't have to look this in detail, but you have to know there is a precise guideline that we have to follow. So the ICANS is a neurological part of the CRS, immune effector cell-associated neurotoxicity syndrome. And when you have such a high amount of cytokines in your blood, it can affect your neurological capacities. The patients will develop headaches, will develop confusion, hallucinations we often see, but finally also speechlessness. They are really in aphasia, and sometimes also seizure or cerebral edema, and finally they can go to a coma. So this is not what we were waiting for. Also, this part of of the side effects, we have to do documentation. The patient is examined 2 or 3 times a day, and we check for his orientation. We check if he's able to write, if he's able to do calculation, and so we see if he will develop ICANS. And there is also a grading of ICANS. If he will develop, for example, seizure, it's considered as severe. And the same is here true then for CRS. There is a grading, and according to the grading, we have treatment options, and we have to give the patient steroids. We have to give them tocilizumab. This is an antibody against IL-6. And sometimes, if it's severe, we have to transfer the patient to the intensive care unit. And here, for example, the treatment recommendations for ICANS grade 1. Once a patient has left the hospital, we have to follow up these patients, and we have to do specific monitoring for blood cell counts. We have to look for EBV and CMV viral reactivation. Lots of patients will develop also a lack in immunoglobulins in the blood, so we will give the patients IVIG to help the immune system to fight against bacteria and viral infections. And the patients will also receive some prophylaxis against infection in the first time, and they will receive acyclovir against herpes simplex. They will receive entecavir if they were positive for hepatitis B, and they will also receive antifungal prophylaxis if they received, for example, steroids, in addition to the immune suppression induced by the CAR T-cell therapy, cotrimoxazole as a treatment, prophylactic treatment against pneumocystis. And you can also see here that the patients will receive intravenous immunoglobulins if there is a deficiency, and in addition, a tendency to infection in these patients. A frequent problem that we can see in the meantime in CAR T-cell therapy, not in the very early phase, but in the phase weeks and months after CAR T-cell therapy, is cytopenia. Lots of patients with lymphoma, myeloma have received 2, 3, or 4 lines of treatment before CAR T-cell therapy. And so the bone marrow is not so fit, so you can see a lot of patients suffering cytopenia after CAR T-cell therapy. That can be due to cytokine release syndrome. It can be explained by the relapse of the disease, for example, myeloma in the bone marrow. But patients have also a higher risk to develop myelodysplastic syndrome or acute myeloid leukemia. The patients have often a long-term lack in lymphocytes, so there is a lymphodepletion. They can also develop hemophagocytosis, or due to the previous treatment, they have simply a bone marrow reserve that is insufficient. So cytopenia after CAR T-cell therapies is a major issue, what we have to consider when we talk to the patients. These are the CAR T-cells possible for the moment here in Germany. You can see here lots of options for diffuse large B-cell lymphoma, but also in follicular lymphoma, in mantle cell lymphoma, in acute lymphoblastic leukemia for younger and older patients, but also in multiple myeloma. One product, the ID-cell product, is no longer on the market because there was disagreement on reimbursement between between the pharmaceutical company and the health insurance companies here in Germany. There is a question between what is the best treatment option, CAR T-cells or BiTEs, so bispecific antibodies with a T-cell engaging capacity. And what is the difference between these two options? When you have a CAR T-cell, I explained to you, you have here the variable domain of an antibody. You have a co-signaling domain, and you have a CD3 zeta part, and you have direct stimulation of the cell. If you have a BiTE, You have also the bridge between the antigen of the tumor and the T cell receptor, but you have no real co-stimulation. So this is considered to be better for CAR T cells. You have co-stimulation, you don't have it in BiTEs. And in CAR T cells, you have longer effects. T cells will act during a few weeks, but you can also measure CAR T cells 2 or 3 months or even 6 months after the CAR T cell therapy. BiTEs are only active as long as you give the BiTEs. When you stop the BiTE treatment, you have also you have no longer effect, and you have a treatment for months or even years. When we talk to patients, most patients with lymphoma, myeloma, prefer CAR T cells because they say, I prefer to go to hospital for 3 weeks and to be off treatment, if possible, for 6 months, 9 months. And in the BiTE therapy part, they will receive therapy for months or even for years without a real stopping treatment during some phases. So most patients prefer CAR T cells, and in addition, the plateau in survival and overall remission rate is only seen in the CAR T cell part and is not seen in the BiTE part as well as we know it for the moment. What will be the development of CAR T cells in the next 1 or 2 years? So there are new CAR T cells coming last year, this year in lymphoma and also acute leukemia and multiple myeloma. But we are waiting for results also in solid tumors, especially in breast cancer, but also in tumors from the central nervous system. We are waiting for results. Also some results in myeloid disease, acute myeloid leukemia, myelodysplastic syndromes. And CAR T cells are going to other domains. And a few years ago, our colleagues from Erlangen published really impressive results of the use of CAR T cells in systemic lupus. Really patients treated with 2, 3, 4 lines of therapy before receiving CAR T cells, and they responded really spectacularly to the CAR T cell therapy. So rheumatology is one of the developing domains for CAR T cells for the moment, and we are also participating in trials with CAR T cells in rheumatological diseases together with our colleagues from the rheumatology department here in Aachen. So that's what I want to talk and explain about CAR T cells in 2025. And we will see you at the next seminar soon, I hope.